resume, but he has spent more than 25 years in academic medicine, most recently as the head of the Allergy and Immunology program at Emory University in Atlanta. He's also spent time in Dallas at University of Texas Southwestern, and he is going to speak to us about food allergies, which is obviously a very important issue since there's a lot of controversy and urban legend revolving around food allergies. So, Dr. Sullivan, and what we will do is we'll hold our questions till after his talk, and if you do have questions, we'll request that you come up to the microphones to ask your questions. So, Dr. Sullivan.
Well, I'd like to thank Dr. Gonzales and you for giving me the opportunity to discuss with you a subject that I find both intriguing, challenging, but also very, very important. It's not possible to cover all the important nooks and crannies, so I'm going to avoid the legends let you ask questions about what I don't cover. But we're going to stick to solid ground, and then we'll see where we go from that. But we'll touch on the mechanisms by which foods can trigger allergic reactions, what their clinical manifestations are, how we recognize them, how we deal with them. I don't have a vested interest in any of this. I have a great deal of interest in the success of recognition and treatment, so if you sense any bias, let me know. It's interesting to me that among patients, when they use the word allergy, they're usually, if they just use it in a sentence, talking about allergic rhinitis. Among physicians and other healthcare personnel, often the word allergy, if it's used not in the context of drug allergy, it refers to an IgE antibody-mediated event. But what I'm going to mean when I say the word, and that's what I would like you to hear, is that we're talking about an immunologically specific reaction. So there's either an antibody or a sensitized T cell that recognizes the antigen. It's a response to an exogenous antigen, so autoimmune responses wouldn't, by this definition, fit in. But also, not only is there a response, but there has to be some pathologic effect. And as I'll describe, it's actually very common to make immune responses to food antigens. Every one of us does it, and does it to many different foods, with not just no pathologic event, but actually protection against some things. So, some years ago, Kurt Bloch at Harvard was the first to really recognize that it was common to make immune responses to certain of the materials in the foodstuffs that we routinely eat. It turned out that those molecules tended to be heat stable, acid stable, and more resistant to proteolytic digestion, so they were more likely to reach the bowel lumen and to be absorbed into the body. And it was that array of proteins that routinely provokes IgA and sometimes IgG and IgM responses. Those are the observations. The hallucination is that the antibodies are in the mucus layer and grab a hold of these undigested proteins and hold them until the digestive enzymes catch up and avoid our absorbing a whole bunch of unnecessary and potentially harmful debris. So an immune response is routine. The purposes of this GI surveillance, of course, are to look for pathogens, make immune responses. Hopefully IgA can bag whatever the problem is before it gets in, but just to reiterate, IgA and IgG responses to some selected food antigens are routine. And it appears this is the reason why, when we first began to be able to measure subclasses of IgG, there was great enthusiasm for the idea that if we detected IgG to foods, then we could have some insight into a pathologic mechanism. And that's turned out to not be correct. There's constant surveillance, and for whatever set of reasons, which are largely not understood by me anyway, occasionally the immunologic environment is such that the antigen-specific B cells are influenced by IL-4 and other factors interacting with regulatory T cells, and we make IgE antibodies. This, of course, is not in our best interest. The IgE antibodies bind to, well, the average mast cell has about 1 million IgE receptors. If we make the IgE, it finds its way and binds to the surface of the cells. And then if the antigen to which the antibody binds arrives, then we get a rather spectacular event. The mast cells are situated, except on the cornea, on almost every surface in the body. They're in the brain. They're certainly all over the place, in the skin, the gastrointestinal tract, the lungs, and other places where pathogens or parasites of various kinds in particular might be penetrating. And I'll get to that a little bit more in a minute. But the main point is, within seconds of the stimulation of the mast cell by antigen or by lipopolysaccharide and certain other factors, there's an immediate release of the contents of the granules within the mast cell. They're called mast cells because Paul Ehrlich, a very bright medical student in Germany, was the first to use stains on tissues and look at tissues under the microscope. And as a result, he was given the privilege of naming a whole bunch of different cells, the eosinophil, the mast cell, and he called it a mast cell because it looked as though the cells had eaten particles of debris in the environment. But there are hundreds of small granules within the mast cells which contain, among other things, histamine, preformed tumor necrosis factor alpha, proteases, and heparin. The heparin that we use is derived from animal intestinal tissues from their mast cells. These molecules pour out very rapidly after stimulation. If you go back and watch the first Superman movie, the explosion of the planet Krypton was actually a video of a mast cell under a microscope being stimulated to release its granules. Within a few minutes, the cells, once the cells are activated, begin to produce a variety of important molecules, prostaglandin D2, leukotrienes of various kinds, platelet activating factor, and influence the environment in a quite different way. And within 20 minutes, you can find mRNA, and within less than an hour, you can find newly synthesized proteins, cytokines that have a whole variety of impacts. And the most important that we're going to discuss today has to do with their interaction with eosinophils, attracting eosinophils and activating eosinophils. So if we make IgE, we're going to sensitize the mast cells, also blood basophils, and some other cells. But in the case of food allergy, it's this cell, the mast cell, that's the key player here. A lot of work has gone into trying to understand why do we have eosinophils and what do they do? And I think that can be summarized in terms of protective immunity by saying the only known role for the eosinophil is to be able to attach to and destroy invading parasite larvae. But the eosinophil normally is bouncing around off the vessel walls, doing absolutely nothing, and it's in a resting state. Mast cells, when activated, release factors that attract eosinophils into the region, cytokines that activate the eosinophil, IL-5 and others, and it becomes a very aggressive killer cell. We can rig it, we can put antibody on a red blood cell, activate the eosinophils, and they blow the red cells away. This is an electron micrograph of an eosinophil attached to the surface of a nematode larvae and eating holes in its surface. It's believed that this is, in protective immunity, one of the main roles for mast cells and probably the only role so far known for the eosinophil. Okay. If we make an immune response, we might have troubles. The IgE antibodies can lead to anaphylaxis, about which we'll talk some. Obviously, urticaria, angioedema, mast cell discharge lower in the tissues or superficial. A variety of gastrointestinal symptoms, in anaphylaxis, and in other situations, it either can be part of a bigger syndrome or isolated to the GI tract. But nausea, vomiting, cramping, diarrhea, sometimes abdominal pain can be provoked by these mediators. And during reactions, at least acute reactions, rhinoconjunctivitis and asthma can be activated. This was sort of a surprise, but shown in blind challenges that unquestionably can occur. That led to a decade or so of work testing everybody with asthma for food allergy, of course finding some, trying to see if it had any role in chronic asthma, and we'll leave a 1% wiggle room, but basically acute flares, definitely. A chronic disease, probably not. This refers to the notion that the immunologic recognition of the antigen may be through IgE, but also either may involve the eosinophils as an effector cell, or alternatively, there may also be antigen-specific T cells. To this day, there's a great deal of, huge amount of knowledge about atopic dermatitis. And you have the mast cell people on one side, the T cell people on the other side, and then neither group obviously has the complete answer. But in any case, that's an immunologically triggered problem in most individuals. Mast cells are activated, whether you can find the antigen or not. T cells are present and activated. Also, you can have organ localized cellular damage, and we'll talk about that some. There are pure, at least as far as we know, pure cell-mediated processes. Especially small children may get contact dermatitis around the mouth, or people working with foods may get contact dermatitis on their hands or other exposed areas. Dermatitis herpetiformis is an intensely pruritic cutaneous eruption with small vesicles, typically on extensor surfaces, can be elsewhere, but it virtually doesn't respond to normal medications, which is one tip-off. But in any case, that's associated with celiac disease. There are so-called food protein-induced enteropathy syndromes. Sometimes it involves the rectum and the sigmoid colon, sometimes throughout the colon, sometimes just the upper gastrointestinal tract. The best evidence we have at the moment is that these are T-cell mediated reactions, and when challenges are done to try to identify specific causes, there's typically about a 2-hour delay, but then it's recommended for that particular kind of a challenge that's done in a hospital, because the children can become dehydrated very rapidly, and you have to be very careful. Nevertheless, it's very important to understand what's triggering it so you can avoid it. We can talk about that some if you like. This is a very rare syndrome, therefore, of course, it's always going to appear on boards, and Dr. Heiner gets credit for having discovered this in California. But essentially, it's at least partially IgG mediated. It's immunologically specific, usually cow's milk, usually in very small children. There's bleeding into the lungs, there's accumulation of hemosiderin, that children may actually become anemic. And it's cured by getting rid of the food that's causing it. Cow's milk usually, but it may be something else. So we have quite an array of things that the immune system can do confronted with food antigens. When various surveys are taken in various ways, and people are asked, are you allergic to a food? Then typically, somewhere on the order of 20 to 25% of people in this country say with great certainty that they're allergic to foods. When some of these populations have been actually studied, that involves looking for immunologic responses and then also doing challenges, then the answer naturally is somewhat lower. It's estimated that roughly 6% of American children at this point, and somewhere between 2 and 4% of adults in the US have current or definitely have had food allergy recently. We're not talking about adults who, when they were little, were allergic to milk. So while it's not everyone, it's quite a few people. The frequency of food allergy in general seems to be increasing and increasing fairly rapidly. I'll just point out one example. Peanut allergy, for which there are a variety of sources of information, has roughly doubled, sort of proven peanut allergy has roughly doubled in the US and the UK over just 10 years. We'll talk a little bit about why this might be, but I'll say up front, we are certain that this is happening. It's happening with asthma, it's happening with allergic rhinitis, but we're uncertain as to just precisely why. But it's a very interesting subject, and there is some knowledge on why. This is the so-called Big Eight. Those that are the most commonly mischief makers: milk, egg, soy, wheat, tree nuts, peanuts, shellfish, and fish. People can become allergic to virtually anything, but these dominate when we're dealing with allergic reactions to foods. And we'll talk about age-related issues here in a second. I'd like to start and put a little emphasis on anaphylaxis, because this is a kind of food allergy that obviously that potentially can kill. I want to be certain that you're aware of how we approach it and how we prepare the patients and see to it that doesn't happen. This is actually a child I took care of. A 6-year-old accompanied his family to a Chinese restaurant, ate a host of potential antigens, including eggs, shrimp, fish, soy, peanuts, and proceeded to have generalized pruritus urticaria, angioedema, then laryngeal edema, wheezing, shortness of breath, and loss of consciousness. In the emergency room, he had a very low blood pressure, heart rate that was elevated, just tachypneic. Standard emergency therapy was given, and luckily he responded. I didn't emphasize it, but tryptase is a trypsin-like enzyme that is synthesized by the mast cells, stored in the granules, and released along with histamine. Histamine vanishes from the circulation in very rapid fashion. It's very hard to catch a rise in histamine during anaphylaxis. However, the tryptase has a half clearance time of hours, and it can be measured. There are commercial assays. And in this case, a sample was taken in the emergency room. It was 58 nanograms per milliliter, and on a subsequent follow-up evaluation, it was back down to a normal, in that case of 2.3. In confusing cases where you're not sure whether you're looking at anaphylaxis or some other syndrome, it can be very helpful to measure tryptase, because if it's up, then it's certain the mast cells have fired. If it's low, it's still possible, but it's a very helpful thing to know about. It's pretty obvious we'd like to be experts at treating anaphylaxis. We'd like to be more expert at avoiding it, of course. So we go hunting antibodies. We can use skin tests. We can use in vitro assays looking for IgE antibodies. In this instance, it was straightforward. The shrimp gave a nearly 25-cent piece sized wheel surrounded by a much larger red flare. And other candidates, some of whom are listed here, were negative. So, in vitro assay showed a pretty high level of specific IgE antibody directed against shrimp antigens. And again, the same things we look for with skin testing were also negative, looked for in the blood. One small caveat: when somebody has anaphylaxis, about a third of the time, the skin test will switch negative, and it may take a few weeks for that to return to be positive. The antibodies are still present. Vulnerability to anaphylaxis is still present, but for some reason, the skin mast cells remain desensitized for a variable period of time. So it's useful to go ahead and test if you want to hunt down the cause, but a negative test right after anaphylaxis ought to be repeated at 2 months. 2 months is the ideal time. Well, but in this case, even though what nearly killed this child was shrimp, the avoidance includes crabs, lobsters, crayfish, because the antigens are almost always muscle proteins that are highly homologous among those crustaceans. This is an interesting syndrome. I don't know if you've seen it. I can honestly say early in my career I saw it, but I didn't know what I was looking at. But some of our colleagues in Denver, Alan Shockett in particular, encountered an individual who was a marathon runner who ran all the time. He really didn't have a life, he just ran. But on 3 separate occasions while running, he had collapsed and had frank anaphylaxis. But he ran every day, and this had only happened 3 times. And as they went through the story, it turned out that he had, each of those 3 times, had lunch at his favorite restaurant and had shrimp. Back to the shrimp. He ate there several times a week with no troubles, but they thought, gee, is it possible that if he, and they tested him and he had IgE antibodies to shrimp, positive skin test. So they said, is it possible that the combination of exercise and subclinical food allergy could actually cause an event? So they went to the restaurant, he ate his shrimp, Dr. Shockett and his fellows got in a car and followed him, and off he went running, and after a couple of miles, down he went with anaphylaxis. So they published this case in 1979. Within a year, there were roughly a dozen reports from all over the world of series of patients with subclinical food allergy associated with exercise leading to anaphylaxis. I am really embarrassed to think what I told the people that I encountered who had this syndrome, but once it was recognized, it became very valuable because, first of all, it doesn't happen every time, and then you go looking and see if you can detect any IgE antibodies, and you avoid those foods. Early on, there were several reports of people with IgE antibodies to celery, of all things, coupled with anaphylaxis. And it wasn't but 6 months after that that I saw an aerobics instructor who said, gee, sometimes after lunch, essentially I crash and burn, and she was allergic to celery at an immunologic level, but clinically she ate celery, no problem. She exercised, and after eating celery, it's a problem, to say the least. So it's peculiar. I mean, the antibodies are there, but there's not enough stimulation ordinarily to get a clinical event. Add exercise to it, and you can have a life-threatening event. There's a second, knowing about this and looking for it, there's a second group of people that have been identified who you cannot detect any antibodies. But it turned out that in this vulnerable group, if they ate a meal, not just a snack, but had a meal and then exercised vigorously within 2 hours, they could have anaphylaxis. And so knowing that can prevent a lot of problems. When we go hunting for antibodies, obviously we in allergy practices are set up to hunt for antibodies. With skin tests, we get rapid information, we get a very broad range of antigens, but also it's useful to be able to detect these antibodies in the blood, and it's very useful for those who are not in the allergy field. So the problem that arose about 15 years ago was that the College of American Pathologists was constantly sending blind samples to laboratories and getting back wildly disparate results when they were measuring IgE antibodies to aeroallergens, to foods, to what have you. And it's a voluntary program, so there are no penalties and there's no disclosure. So it just went on. And the question was, were people just making these results up, or were the tests not so good? So these are two papers that show you the results of an inquiry that I instigated. What we did was we sent 17 serum samples to 6 different laboratories that were using 5 different commercial assays. Many of them were homemade assays, which can be done if you're careful. And then the Pharmacia, at that time, immunocap system. We sent the very same samples 3 times a month apart, all with phony names, to see what kind of reproducibility the laboratories could provide. And we had some samples that were extremely positive to cat or to house dust mites or other things, and we diluted those sera serially with negative sera to see if the assays were linear. I'm not going to inflict the data on you, but what I can tell you is the only assay that was acceptably reproducible was the immunocap assay. And for that reason, when you send blood samples, you ought to specify that that's the kind of assay you want. It's a commercial assay. Various laboratories in this region use it, but in some cases, it might be diverted elsewhere, and that means that you're going to have a much harder time interpreting the data. So it seems like an arcane point, but it's real important if you get negatives when it's smoking hot positive or vice versa, and that is what we found. Okay, so the virtues, though, are that any of us can order these in vitro assays. You would prefer the immunocap assay, which several of the commercial groups around here do. It does have slightly less sensitivity, that is, it misses some of the allergic people, but nevertheless, it's convenient compared to skin tests. And it provides quantitative data. When we follow people, especially small children, with food allergies, which typically as the child gets older, if they avoid the food, will go away, we'd like to know when it's gone away, or when the levels are so low that the family doesn't have to avoid wheat or corn or milk. It can be very helpful. So in any case, it gives you quantitative data that's helpful right along with the skin tests. Skin tests detect antibodies more readily, but we may have a positive test and no clinical reaction, as we just described when exercise-induced food-associated anaphylaxis is concerned. Some of the food antigens are not very stable, and that's actually important and interesting. We'll get to more of that in a second. But the materials we use for skin testing are several months old by the time we get them, and sometimes the history is striking. The test is negative, for example, with apple, peaches, pears. You get the fresh fruit, put a drop on the skin and scratch it, and you get a wild wheeling flare. So we can have problems there. Similar problem, of course, with the antigens for in vitro studies. But you can use fresh foods, especially fruits, and do a skin test if there's a need to do that. At the end, I'll show you how to find all of this if you're interested. This is posted on a website that you can go to and read or download if you wish. So, but in any case, this organization used to be called the Food Allergy and Anaphylaxis Network. They now, for whatever reason, call themselves the Food Allergy Research and Education Operation. If you plug anything of that sort into Google, you'll get them. It's very valuable. For example, you can print off food anaphylaxis or food reaction action plans that are really very good, very useful, easy for people to understand, parents and teachers, whatever. It's a valuable resource. This is the specific citation if you want to go straight to the food allergy action plan. And this is one source for people that are looking for allergen-free materials. Okay. Now, if we have anaphylaxis, epinephrine is the drug of choice, but it's reserved, or should be reserved, I think, for situations in which there's threat to the airway or cardiovascular collapse. In other words, if there's reason to be concerned that swelling of the tongue or the laryngeal tissues is threatening the airway, it's time to use it. If there's evidence of an allergic reaction and there's tightness in the chest, shortness of breath, wheezing, it's time to use it. It's very hard, of course, to judge whether somebody's hypotensive or not, but if a normally alert person, coupled with urticarian angioedema, cramping, abdominal pain, and vomiting after a bee sting or food ingestion is getting lethargic, it's time to use it. I'll get to the preparations in a second, but it's very important for those of you who have never had epinephrine injected into you to understand that it stings. It's not bad. Boy, there are some things we inject that are really quite uncomfortable, but epinephrine stings, burns, hurts, all in no capital letters. But a child will retreat. In other words, as soon as it starts to sting, they're going to try to go backwards. So, with the little bitty things, you can grab them under the arms, swing their feet out, put them on the ground, and then inject it into the upper outer thigh. For older children, it works better to stand behind them, put your arm around the chest, reach around, give it to them in the thigh. That way they'll back up into you. Older people will pretty much get it. The purpose of this picture, though, is to make the point that these devices were originally designed to give chemical warfare antidotes. They were designed to go straight through military uniforms. There was no virtue in getting clothing off in the case of a chemical attack. In any case, this is intended to go straight through clothing, no time wasted. We have a break. For a long time, the only preparations that we had for self-administration, we had a few others, but the main one was an EpiPen, which costs a lot of money. It also should be dispensed in two. I'll get to the reason why. But now there's a new product, which is also a self-injectable epinephrine. It's called Auviq. It sort of looks like this instead of like the traditional EpiPen. One of the cute features is that once you pull the top off this thing, it begins to give you verbal instructions as to what to do. Both of these are very effective. They come in two strengths 150 micrograms, 300 micrograms. The dose, if we were to draw it up, is 0.1 micrograms per 0.1 per kilogram. So a 33-pound child would be perfect for this, and a 66-pounder and up gets the full strength. These companies are competing, and both of them have discount programs making the costs of epinephrine now very affordable. And this means it's much more likely that when you make a recommendation and prescription that it'll be filled. Just be sure to direct them to these discounts, make it very inexpensive. The reason we dispense 2 of each, there are 3 basic reasons. One, in some instances, the anaphylaxis is not going to respond to the first dose, and a second dose is necessary. Secondly, there is a phenomenon called biphasic anaphylaxis, where hours after the first event has subsided, it comes back. So bear that in mind. And they should refill their prescriptions if they have to use it. Obviously, they should be talking to you or seeing a physician somewhere. In any case, we have 2 self-injectable forms. Both are very effective and both are affordable now. The EpiPen is probably more familiar to you. Take it out of its case, you pull the blue cap off, you press the orange tip against the thigh. They say hold it down for 10 seconds. It works much quicker than that, but that's fine. And they recommend massaging the area for 10 seconds. There are a lot of data that say if we just injected epinephrine into each one of us, it would take an hour for the blood level to peak. It's absorbed very slowly because in the subcutaneous tissues, it clamps down the vessels and it slows up absorption. In the situation of anaphylaxis, the cardiac output, when it's been measured, is anywhere from 1.4 to 1.7-fold increased. Blood flow through the subcutaneous tissues is markedly increased, and the drug is swept up very efficiently. It's supposed to be given IM, but the needle's only 5/8 of an inch long, and most Americans, you're still in adipose tissue. Same idea here. You pull off the case, it begins talking to you. You pull off the red safety guard, put the black end against your thigh, hold it down for 5 seconds. It's very important that you explain to the patients which ends of the devices the bullets come out of. I've had one individual who was the CEO of a pretty big company who thought he was plenty smart, but he didn't have to listen to me. And so he had exercise-induced anaphylaxis and proceeded to need his EpiPen. He took it out, pulled the cap off, and then got confused as to which end was the action end. So he started banging away on his thigh, nothing happened, so he put his thumb over the end to do it harder. It pierced the tip of his thumb. He said it shot the epinephrine over his shoulder, and he wasn't sure whether it was the humiliation or the pain that stimulated his own epinephrine. But that's children retreating and then using the wrong end of the device are the 2 most common ways this thing goes wrong. Okay, let's change our focus here a minute. Among children, cow's milk allergy is the most common in young children. It's antigenic, and that's one of the first things most of them are exposed to. Chicken egg allergy is most common in older children, and then over 4 years of age, the most common food allergy in the United States, at least, is peanut allergy. Interestingly, there are countries such as Israel where there's a lot of peanut consumption and very little peanut allergy by comparison. That's certainly been looked at and is still being looked at, but it's not understood. Okay, if you're following these people, and some of these children will have several important food groups that they're allergic to, but we know with time, most of that will go away. The shellfish, the tree nuts, peanuts may go away, but it's much more gradual and less likely than things like eggs, milk, corn, wheat. But every 6 months or so, you can check them either by doing a skin test or measuring specific IgE antibodies in the blood. And we'll not go through the fine details here, but if it gets very low or else goes negative, then we can do oral challenges, make certain that the person's no longer allergic, and this really frees a family up. You'd think this is a big rigmarole, but the truth is, it's very hard for families to rigorously avoid some of these things. Okay, we're going to return to this enraged mast cell, but focus on our partner in host defense, the eosinophil. And what we're going to focus on for a minute here is a phenomenon called eosinophilic esophagitis. I'll show you pictures in a second. But curiously, this is most often a food allergy, and oddly, it's usually restricted. The inflammation is restricted to the esophagus. It's a through and through, not just the surface, but through and through inflammation involving eosinophils, mast cells, and most of the time is food antigen driven. These people have a high frequency of other allergic disorders such as allergic rhinitis, asthma, atopic dermatitis. And among adults, there's also a high frequency of these. You can't rely on peripheral blood eosinophilia. It's present in 40 to 50%, but its absence or presence doesn't really tell you anything. Total serum IgE is elevated in half, which is a surprise to me because most people who have allergic rhinitis or asthma or atopic dermatitis have an elevated IgE. But in any case, that's not helpful. The only way that you're going to, and I'll get to the clinical manifestations in a second, but the only way you can make this diagnosis is with the help of a gastroenterologist and biopsying the tissues. This is not a normal esophagus. However, sometimes the esophagus through the endoscope looks normal, but the biopsies can look like these. The little arrows point to some of the eosinophils here. The general criterion is in random high-power fields, if the pathologist sees an average of 15 eosinophils per high-power field or more, that's very strong evidence for eosinophilic esophagitis. And the inflammation extends all the way through the wall of the esophagus, not just in the very superficial areas. The clinical manifestations and the complaints differ a lot by age. It is more common in adults than it is in children, but it certainly occurs in little bitty things. And it manifests itself with feeding difficulties. It's among the many things that has to be considered. Among school-age children, vomiting and abdominal pain tend to be the predominant complaints. In adolescents, we begin to see situations where they'll complain that food seems to it's difficult to swallow, particularly solids, and it sometimes feels as though food gets hung up in their esophagus. And then among adults, dysphagia is very common. And very often they'll say, well, I've had this for 15, 20 years, but it's really just gotten worse. But chest pain, which has many potential explanations, this is one. Food impaction, in other words, the food really gets stuck and they can't get it out without the help of a gastroenterologist. Then upper abdominal pain, typically epigastric. Not all of these folks do get food impaction, but the estimates are that between 33 and 54%, depending on the series, do have food impaction to the extent that they need endoscopy to remove the obstruction. There are a lot of data that suggest that food antigens are the primary source. We'll get to the idea, and it is true. Rarely, the antigen is actually an aeroallergen that they have become allergic to. The fate of all the pollen and mold and animal dander is to be picked up in the moist secretions, and we swallow it. We always swallow it. And it turns out, oddly, that one potential source of antigen that leads to eosinophilic esophagitis is inhaled antigens, but we're really almost always dealing with foods as far as we currently understand it. This is a high value, but there have been studies that up to 97% of people put on an elemental diet. That is to say, pure amino acids, sugars, vitamins, minerals. You're probably familiar with that for various reasons. If little children can comply with that pretty well, and then up to 97% have clinical and biopsy improvement. And then by adding back foods, roughly 84% can identify the cause and then get on with life. These preparations, these elemental diets, those of you who haven't tried to inflict them on any of your patients, are really not too appealing to adults. And it takes 4 to 6 weeks before the avoidance really pays off and the esophageal changes, that is, the abnormalities are pretty much resolved. So that 6 weeks of an elemental diet is a hard sell. So you don't want to recommend something they're not going to do. That's my point. If you can talk them into it, that's really good. There's one approach that's been used, that is to select these foods: milk, corn, peanut, wheat, beef, soy, and eggs, and a significant number of people will improve. That's quite an undertaking, of course. More sensible, if you can, is to test to see what IgE antibodies these people express, and then avoid foods for which there's a matching IgE antibody. And when you do that, then roughly 80% of the people with eosinophilic esophagitis are going to improve, because you can get rid of the cause, have the tissues heal. And when those things don't work, we turn our attention here. It should be quite simple to rectify with immunotherapy, but on the other hand, that's rare. The most common treatment for the inflammation is to use the metered dose inhaler fluticasone, intended for use in asthma, but to have it just hold their breath and fire it into the mouth and then swallow it twice a day. High dose fluticasone can be very effective. There's a viscous form of budesonide that has been available that can be swallowed once a day. I don't think there are any head-to-head trials, although the opinions of most who deal with this a lot are that probably the fluticasone is a bit more effective. Some of these folks will have significant acid reflux, and if so, it simply just is gas on the coals. And so acid reflux ought to be attacked very vigorously. These dysphagia and the food impaction is usually a result of narrowing and scarring of the esophagus, and you would think we'd just get down there on a regular basis and dilate, but those tissues are somewhat friable, and the likelihood of an esophageal perforation during dilation is much greater than if it was a stricture induced by acid reflux, for example. So it takes a gastroenterologist with good skills and good judgment to decide when and how to do the dilation. But the fact is, despite its dangers, it's frequently needed in adults. Okay, I'm going to change gears on you again here a little bit. Right now, we still have a fair amount of birch tree pollen in the air, and quite a few people who have springtime allergic rhinitis are allergic to birch. Some of those people, not all, but many, will tell you that when they eat apples, their mouth, the buccal mucosa, their palate, their throat itches. They don't get urticaria or angioedema or anaphylaxis, but they get pretty intense oral itching. I'm not going to give you the whole catalog, but you'd be astonished at how many people who are allergic to birch will have trouble with certain foods. Apple is the classic one. Mugwort, a weed that pesters us in the fall around here, provokes antibodies that in some people cross-react with antigens in carrots. Totally different plants. Ragweed allergic people may have oral allergy symptoms when eating cantaloupes, and I'll show you a few others. What is that all about? Well, this is a rubber tree. This is an individual who's tearing a hole in the side of the rubber tree to let the sap come down here and collect overnight, from which we get our various natural rubber latex products. From the tree's point of view, it's been slashed open, and it's open to insects, viruses, bacteria, and the trees respond with an array of proteins that can be referred to as defense proteins. I'll give you a couple of examples in a minute. They don't have antibodies, they don't have T cells, but they can elaborate substances that make insects sick and less likely to chew on their leaves, and have antibacterial, antiviral, antifungal effects. Well, it turns out that in bananas, kiwis, water chestnuts, and avocados, there are similar defense proteins that are sufficiently similar that if the latex allergic person has made antibodies against those defense proteins, which is commonly the case, then these totally disparate foods can provoke oral allergy, or sometimes systemic anaphylaxis in this case. This is a catalog of known oral allergy provocateurs. The sensitization was with ragweed pollen, and yet some people will react to defense proteins here in bananas, cantaloupe, cucumbers, zucchinis, honeydew, watermelon, even chamomile tea. So it gets a little confusing, obviously. The sensitization is actually through the respiratory tract. The antibodies were made in response to an inhaled antigen, but because in some instances the antibodies are made against defense proteins that are expressed in disparate plants, you get food reactions as a consequence of inhalant sensitization. People have gone to the trouble of dignifying this with type 1 allergies to foods, in which you swallow the food, you make antibodies, and you have a reaction. These tend to be heat stable, acid stable, and resistant to digestive enzymes. The type 2 food antigens are those that I just sort of hinted at that cross-react with materials that were in the aeroallergens, but fortuitously cross-react with food antigens. These typically are heat labile, acid labile, and very susceptible to digestive enzymes, which is the reason that in most instances it's reactions in the mouth, in the oropharyngeal region. Once it hits the gastric acid, their history, and they don't generally cause systemic reactions. There are a variety of these proteins known. Some are called pathogenesis-related proteins, lipid transport proteins, but they actually attack microorganisms, chitinases. There's some seed storage proteins that are effective against funguses. But these ideas have been conserved in a variety of disparate foods, and it can be very confusing to try to predict. It's even more colorful because, for example, organic farmers very often spray chemicals on the plants to provoke defense proteins so that the insects don't eat their crops. They're not pesticides. They're trying to get the tomatoes and other plants to make their own defense proteins. But the point is, a tomato you grow in the backyard without any of that may cause no trouble. A tomato you buy that's either organic or from the grocery store may have been treated in one way or another to provoke these proteins, and you have a reaction. So trying to get a medical history that makes sense can be a challenge. Nevertheless, that's what we face. A couple of ideas about what might be around the corner. As some of you know, it's routine now to be able to desensitize people allergic to antibiotics. If they've had an IgE-mediated reaction to penicillin or virtually any drug, including chemotherapeutic agents, we virtually always can get that drug in there safely. Typically, we build up over 4 hours, watch them for 2 more, and almost never have any problems and no anaphylaxis, with the exception of the platinum drugs, which cause pseudoallergic reactions too. So the idea was, well, if we can bypass the IgE mechanism, it desensitizes the mast cell. The antibodies are still there, the mast cells switch off the response, and you can treat. Why can't we do this with foods? And so there's been a lot of work in the last few years doing this. It was stymied about 10 years ago when the people of the National Jewish in Denver were dealing with a lot of people with really bad peanut allergy at a time when the packages weren't labeled. If the food wasn't 5% by weight, it didn't have to be on the label, and so there were a lot of accidental exposures to peanuts, and they had a cadre of people who'd had life-threatening reactions, and so they tried a desensitization protocol. And some of you may know that there was an accident made in the pharmacy. They sent up a very high-strength material for somebody who was supposed to get a very low dose, and a 16-year-old died of anaphylaxis. So that was very sobering. It led to very stringent reviews of how we do things. But they had the courage to finish that study and show that it was feasible to build people up, most of them, to a level that they could at least have accidental exposures to peanuts and do well. So I'll show you a couple of examples. We'll talk about vitamin D. Okay, move quickly here. There are two recent papers that tell you the state of the art for oral desensitization, and this sublingual immunotherapy by a very responsible group, a randomized, double-blind, multi-center, placebo-controlled trial. They were able to get most of the patients up to what they described as a modest level of desensitization, safer, but their method had very few allergic reactions. This study, published a year or so ago, aimed to get 200 milliliters of cow milk into the kids. 86% of them were able to do that, but 25% of these people had frequent, severe, and unpredictable allergic reactions, even after they got them up to a maintenance dose. The consensus is that we're on the way, but this is way too dangerous to do. If we could neutralize the IgE, that'd be great. There was one successful study published years ago, but there's no indication for its use, and there are no trials underway at the moment, so, but one day perhaps. It's been known for some time that if you're born in the fall, you were much more likely to develop food allergy than if you were born in the summer, which led some to speculate maybe it had to do with vitamin D. Those people who live way north have more food allergy than those who live in the more sunshine bathed parts of the world. This study from NHANES data showed that kids with vitamin D levels are quite low, 15 nanograms per mil or lower, were 2.39-fold more likely to develop allergy to peanuts and 4.75-fold more likely to be allergic to oak pollen, indicating that vitamin D insufficiency may be playing a role in the increasing frequency of these problems. So, we've blasted through a lot of ideas. The key notion here is that think about food allergy, find the antigen, make sure people know what to do if things happen. There are good resources you don't have to memorize or have on hand, and you can do a lot of good for your patients. These ideas, if you wish to pursue them, are on a website called DescribeD, where you can go at no cost. Just plug in Food Allergy 2013 and download or look at these ideas. Thank you very much for your attention. I hope it helps.
Thank you, Dr. Sullivan. We have a few minutes for questions. Please go up to the microphones. Thank you.
I would have a question on the shellfish allergy, for example. How long without an exposure does it take for the allergy usually to remit? And also on the oral challenge, wouldn't that just resensitize the mast cell?
Okay, well, the question was, how long does it take for allergy to foods to go away if there's strict avoidance, and wouldn't a challenge and then reintroduction of the food lead to resensitization? An answer 5 years ago to the question about cow's milk and eggs, for example, in small children, was that within a year, most of them would lose that allergy. And that was based on data. Now the data say that typically it takes more often 3, 4, 5 years on average for those kinds of allergies to disappear. Now again, the peanut, tree nut, shellfish are much slower to dissipate. So it may occur in a year the way it does and has in some, but it may also take several years before, even with strict avoidance, for that to go away. There are data on resensitization, and the highest rates of resensitization that I have seen were in the 7 or 8% range. Most don't get clinical reactions, but the tests become positive. So that, in other words, they're constantly eating the food, so it could be they're sustaining a form of desensitization. But it is a risk, but on the other hand, if 19 out of 20 allow the family to have a much more liberal diet, it is something to give some serious thought to. Yes, sir.
2 questions. One's really quick. I was just wondering, you mentioned that the IgE skin testing can often be negative for 2 months after an anaphylactic reaction. Is the same true for an immunocap test?
No, it's not. A lot of the data that we gathered had to do with penicillin, and if somebody has IgE antibodies and we desensitize them, the mast cell goes negative. It reverts back to positive within 2 days after you stop the drug. But if you look in the blood, the detectable IgE drops by about a third, but if you have a sensitive assay, you can still detect the antibody in the blood. But I would emphasize that 2 out of 3 times the skin test will be positive. So when you're seriously looking for a cause, it's not that you shouldn't do it, but you should understand that a negative skin test right after anaphylaxis can...
Maybe false positive. Or maybe.
Yes, sir.
And then the other one is, is there any way to definitively diagnose a non-IgE food allergy?
Oh, absolutely. Some of these food protein-induced enterocolitis syndromes in children are dealt with by removing the likely candidates, and if the problem stops, like getting rid of the big 8, so to speak, then that's sort of a big task to avoid them all. And so often challenges are done to see if you can reignite the issue. And as I said, some of those are pronounced reactions, but yet the data are valuable. So, but it's really not based on immunologic tests. It's based on removing an array of potential causes. If things improve, returning them cautiously one by one. It's awkward, but that's the best we have at the moment.
The elimination diet is really the only way to do it.
I'm sorry?
The elimination diet then is the only way to...
To my knowledge, yes. Looking for specific T cells hasn't been helpful. Looking for specific IgG or M has not been helpful, and yet they are immunologically specific.
This question is a little bit on the periphery of your talk, but we have a lot of patients on immunosuppressive therapy for various diseases. Do you have a different approach to desensitization therapy when people are on immunosuppressives?
Well, it's a really good question. I was kind of hoping you'd say immunosuppressed patients, because we almost pray for the situation where somebody is getting cytoreductive chemotherapy who needs to be desensitized, because if you introduce an antigen in the context of you've got drugs sitting there waiting for a cell to divide and kill it, you can knock out immune responses beautifully. If you make the mistake of giving Pneumovax, for example, to somebody who's on cytoreductive chemotherapy, their anti-pneumococcal antibody titers will go from measurable to unmeasurable. You kill out those B cells. So that kind of immunosuppression is actually helpful, but rare. As far as people, transplant patients who are on various kinds of alkylating agents and cyclosporin and glucocorticoids and other agents, they're working in our favor, so to speak. They do not increase the reactivity of the mast cells or responsiveness of the tissues to the damage. I mentioned vitamin D real fast, but it's one thing we should look for and can correct that could be very helpful in reducing the severity. You probably know that vitamin D deficiency, when corrected, makes osteoarthritis, rheumatoid arthritis less intense. There are a whole array of benefits of getting vitamin D straightened out, and that's something to think about. But no, I know of no reason to worry about that situation. They're more vulnerable people, of course. You don't want to provoke anaphylaxis. We try hard not to. Yes, sir.
Briefly, does food allergy cause skeletal eosinophilic myositis? Skeletal muscle eosinophilic.
Well, the only, to my knowledge, which may be flawed here, no. But there's the eosinophilia myalgia syndrome, you recall, from people taking L-tryptophan that was contaminated by a still unidentified contaminant, which caused intense and prolonged myositis characterized by eosinophilic infiltration. So an external substance unambiguously caused eosinophil-mediated damage to muscles, but I'm not aware of evidence that foods do that.
Thank you, Dr. Sullivan. Over the last few years, the Ogden Surgical Society has had a relationship with the National Kidney Foundation of Utah and Idaho, and the next two speakers are both associated with this combination of the Ogden Surgical Society and the National Kidney Foundation. And part of the reason for this is that kidney disease is an unrecognized problem in many people, and there are some statistics that I would like to point out. One is that a third of adults are at risk for developing kidney disease, and 26 million Americans have some form of kidney disease, stages 1 through 5. If you will look at the handouts that were given to you by the Kidney Foundation, these pads can help you diagnose these patients, and these are informational and helpful in terms of educating your patients, so that chronic kidney disease is unrecognized, and the Kidney Foundation of Utah and Idaho is very happy to have the relationship with the Ogden Surgical Society. So the next speaker